Look at any city at dusk, and you see millions of human intersections. When a health crisis hits, responding requires a massive, invisible ground game. This chart shows the complexity. You need epidemiologists tracking the outbreak, community workers, and city planners, 20 distinct roles operating simultaneously. In practice, these professionals operate in isolation. They use disconnected software and speak entirely different languages. The lines of communication break down. When an outbreak accelerates, these teams often rely on static PDFs and reference libraries for guidance. Searching through a multi-page document for specific protocols consumes hours that a community cannot spare. Public health resilience depends on the ability to synchronize these distinct roles. Without an execution system to bridge the gap, even the most expert workforce remains fragmented during a crisis. An operating system moves beyond the passive storage of a reference library. It actively triggers specific workflows the moment data arrives. When an agency attempts to push data from a community health screening into a municipal planning database, the formats clash. Cross-sector partners spend their time manually re-entering data instead of acting on it. Rapid response requires a unified system that initiates work automatically, removing the need for manual human translation between departments. This is Access to Health. It is an open-source AI operating system built for the public health workforce. To see how it handles a crisis, we can run a stress test using one of its built-in modules, the Disease Outbreak Response Cross-Role Workflow. The sequence begins on the ground. A community health worker conducts a social determinants of health screening, gathering specific details about a patient's living conditions and symptom onset. Instead of burying that screening in a static file, the worker executes a built-in / command. The system immediately starts routing the information to the relevant departments. Look at this decision tree diagram. The AI processes the community health worker's prompt and routes the screening data downward. It takes one input and instantly delegates tasks across the entire organizational pod. A single data entry point coordinates an entire public health department simultaneously. The system assigns specific next steps to the correct staff the second the screening is submitted. For the epidemiologist, the system auto-generates real-time surveillance data, highlighting demographic spread and transmission vectors before the morning briefing even begins. Simultaneously, it routes customized guidelines to the health educator, generating population-specific workshop designs tailored for the exact neighborhoods affected. It also delivers a drafted alert campaign to the communications specialist. Using a built-in bilingual layer, it formats the public warnings in both English and Spanish simultaneously. Generating over 60 distinct reporting and communication artifacts removes hours of administrative drafting. This allows professionals to move into their actual fieldwork immediately. The system also communicates outside the health department. Data engineers need this information, as do city planners and local government officials to coordinate transit and zoning responses. This diagram illustrates how the platform uses the FHIR R4 data standard. It acts as a universal translation layer, allowing external databases to plug directly into the operating system. Financial officers can run the same data through an integrated ROI calculator, using evidence-based intervention profiles to track costs and secure cross-sector grant funding. By standardizing how data moves, public health transitions from an isolated department into an integrated component of city infrastructure. This system is currently operational as the Missouri Reference implementation, supporting both dense urban centers and rural plains. Because the underlying architecture relies on standardized commands and templates, it scales to any municipality in the country without requiring a custom codebase for each city. Health infrastructure does not exist in a vacuum. The Access to Health platform is one operational node within a much larger civic framework. As this diagram shows, it is part of the CoTrackPro Access to initiative, locking in alongside operational systems for justice, education, housing, services, peace, and safety. The entire repository operates under an open-source MIT license. Communities can download the codebase and deploy the system freely, avoiding the restrictions of proprietary vendor contracts. Providing this executable AI toolkit as open-source infrastructure gives communities the technical foundation they need to coordinate and deliver health equity.